Very warm welcome, my dear friends, my dear doctor friends. How are you all doing? I welcome you to missed YouTube live session in which we'll be discussing 25 most important ophthalmology questions for your upcoming December 2022 FMGE exam. A very good evening to you, doctors. I hope all of you are joining. Very good evening, friends. So as we know, we are in the last segment of our preparation for the exam, and you have done a lot of hard work. You are doing a lot of hard work. And these sessions in which we are going to discuss the important questions, they will give you a high yield areas which are important from where we expect the questions to be coming. Okay, so friends, the questions which come in the exam, they may not be of the exact language, they may not be of the exact wording, but these topics which we are going to discuss today, they form the most expected, most important ophthalmology topics for the exams. They have been coming in the past, and we expect that going through these questions will help you in your upcoming exam. So without any delay, I want to start the session right now. Let's gear up. Let's be here with full attention of ours to start discussing ophthalmology questions for you. Okay, so are you all ready, friends? Okay, so I'm Dr. Anuradha Dhawan, and let's launch this session. So friends, come and start with the first question of the day, Thank you so much, guys. Thank you so much. Right. So the first question of the day is an image-based question. I have seen in the last few exams, they have been giving you an image and asking you to tell or name the lesion which has been marked there. Okay. So let's start with that. The question is, the marked lesion in the image is seen in which of the following conditions? The choices given to you are choroiditis, conjunctivitis, interior uveitis, posterior uveitis. Now, in these kind of the questions, of course, you have to look at the image very carefully. First of all, try to see that what is the structure in the image which they are going to show you. So I'm very sure all of you know that this is a slit lamp image, right? Yeah, you guys are wonderful. Most of you have already given the right answer. But let me explain to you how we arrived at this answer. So you see, this is a slit lamp examination. The image is showing a slit lamp examination, and you are looking at the corneal slit here. Okay, so this is the corneal slit here, and you are seeing these multiple whitish mutton fat like spots at the back of the cornea, which are known as chorotic precipitates. These are known as chorotic precipitates, or in short, we call them as KPs. And these KPs, which you are seeing in this particular image, they are a very big one. They are known as mutton fat KPs. Absolutely right. The mutton fat KPs, the big sized KPs, they are feature of granulomatous type of uveitis, granulomatous type of the inflammation. The second type can be fine KPs or small sized KPs. The fine or the small sized KPs, they are seen in non-granulomatous inflammation, right? So this is all about KPs. And yes, you are very right, Vineet. The KPs are specifically present, or they are arranged in an inverted triangular manner. And this inverted triangle is known as Arlt's triangle. This is known as Arlt's triangle. Okay. So absolutely right. You have identified this lesion. Absolutely right. KPs, and KPs are a hallmark of anterior uveitis. They are hallmark of anterior uveitis. So C is your right choice, as you already told me. Now, besides discussing about the keratic precipitates, which we have already done. Let's quickly go through the various other signs in anterior uveitis, which they might ask you. Okay, so anterior uveitis, when we speak, that is iridocyclitis. So there can be, as we know, anterior chambered cells and flare. KPs you have already told me. Then can you tell me what do you see in this image, friends? What do you see in this image? You can get an image like this also. So here what are you seeing is that your pupil has become irregular because the pupil is adherent. The iris is adherent to the lens. So if they tell you to mark this lesion, these are posterior synechiae. These are posterior synechiae, friends. Absolutely right. Okay. Then this was a question in the last exam. They asked you that the coep nodule or Busseca nodules, they are present where? The nodules, they are also seen in the anterior uveitis, and these are your iris nodules, which are present on the iris. So sometimes you can get an image like this also. So there are two kinds of the iris nodules which we see. When they are present in the body of the iris, we call them as Busseca nodules. And when they are present at the pupillary margin, we call them as coep nodules, right? So another question can be asked, iris nodules, Busseca and coep are the type of the iris nodules which are seen again in granulomatous anterior uveitis, right? So that covers your anterior uveitis. That covers all the signs which they can ask you in the case of anterior uveitis. An important topic for the exam, dear friends, a favorite topic with the examiners. Okay, right? Okay, so after this, let's move on to the next question. Now, clinical case scenario questions are again very important from ophthalmology point of view. For your exam, in clinical case scenario questions, try to read the case statement carefully. As I always tell you, try to pick up the key information, the key words which help you to go for the diagnosis, and always try to see that what the choices they are asking, whether they are asking a diagnosis or a management or an investigation, what are they asking? Okay, so let's move on to the second question, friends. A 75-year-old female. So for ophthalmology, age groups are very important because certain diseases are more common in certain age group. So here it's an elderly age group, 75-year-old female. Distortion of letters on reading, right? So what is the distortion of letter on readings, dear friends, known as metamorphopsia? Metamorphopsia. And if you remember, metamorphopsia is especially a symptom in macular diseases. Macular diseases. Metamorphopsia is a symptom which is seen in macular diseases. So if you take it, you already have your diagnosis almost ready. Okay, let's go ahead. She also suffers from hypertension, hypercholesterolemia. Her fundus examination shows yellowish deposits in the macula as shown in the given image. What is the diagnosis? So patient is elderly. Patient has symptoms of macular disease, which is metamorphopsia. And you have the classical image which they have already given, in which you see yellowish deposits. Absolutely great, my dear friends. You are at the right diagnosis. But how do we identify in the fundus image what you are seeing here? So you are noticing all these different yellowish spots which are in the macula, and rest everything is normal. The disc is normal, the vessels are normal, no hemorrhages are there. So these spots, what are these spots known as? These are drusens. These are drusens, the yellowish discrete spots in the absence of any other vascular feature. That is how you will differentiate it from the hard exudates, because hard exudates are present with the retinal vascular diseases. So if it's only yellowish deposits in the macula and rest everything is appearing normal, it means these are drusens. So in your choices, let's go through the choices quickly once. The choices they gave you were hypertensive retinopathy. So you don't see any hemorrhages, any changes in the vessels. So hypertensive retinopathy is ruled out. Dry age-related macular degeneration is the right answer here because it's a macular disease. You are seeing the drusen's here. Hypertension and hypercholesterolemia, they are one of the risk factors for dry AMD. Okay. Then Best disease. In Best disease, we see a single egg yolk like yellow spot in the macula. Remember, the egg yolk appearance in the macula is seen in Best disease. This is not the thing which you are seeing here. Then D, crystalline retinopathy. These are not the crystalline retinopathy because they are usually the shiny crystals, and they are because of the toxicity of the drug. Mostly which drug? Tamoxifen, friends. Tamoxifen toxicity is the one which leads to crystalline retinopathy. So do not confuse these drusens with the crystalline retinopathy. So I hope the diagnosis is very, very clear. Dry age-related macular degeneration. Now, if they give you an image of wet or exudative type of age-related macular degeneration, how are you going to differentiate them? Now, exudative type is also known as, if you remember, friends, neovascular AMD. Neovascular AMD, age-related macular degeneration. Yes, absolutely right, Selva, about the tamoxifen toxicity in CA breast cases. Now, neovascular exudative AMD or exudative AMD, whenever there is new vessels, I always tell you, friends, whenever there are new vessels, there is bound to be some hemorrhage, some bleeding there. So in that kind of age-related macular degeneration, as you are noticing here, you will see there is bleeding in the macula, these hemorrhages, you can make it out. So if there are hemorrhages in the macula, in the form of, they are actually subretinal hemorrhages under the surface of the retina, then that is a case of neovascular AMD. And another point I want to tell you about the treatment for the dry AMD. The treatment is giving antioxidants to the patients, friends, so that to prevent any further progression. And for neovascular or exudative AMD, we give anti-VEGF intravitreal injections. Okay, because these are very commonly given. If there is a question, what is the treatment of exudative AMD? That is anti-VEGF injections. So again, an important topic for your exam, age-related macular degeneration. Okay. Okay. So coming to next question, which is very commonly asked. Often I have also asked you different forms it has been put. So I think the diagnosis again can be instant. Yes, beta, bevacizumab is one of the anti-VEGF. There are ranibizumab also available. And then there is another one which is by the name of aflibercept. Okay. So anti-VEGF are the drugs which are given for exudative AMD. Okay. Now coming to this question, next case scenario. A young boy, so again, the age group, it's a young boy, which is there, is brought by the mother with itching and ropey discharge. So these are the two keywords here, beta, itching and ropey discharge from both the eyes. His eyes, they show raised lesion on the limbus and on everting the upper lid. So they have given you the sign of the condition, raised lesions on the limbus and on everting the upper lid. Which of the following could be the diagnosis in this case? So before even going through the choices, keep in your mind a young boy with itching and ropey discharge. Beta, ropey discharge is a feature of allergic conjunctivitis. Okay. Allergic conjunctivitis. And in young boys, the allergic conjunctivitis, which is commonly seen as, you know already, spring catarrh. Okay. But this question, though it is very simple question, but this has been asked repeatedly in your exams. So please remember the signs and symptoms. Raised lesions which they are talking about are the papillae. They are the papillae that they are talking about. Papillae, when they are present on the limbus, they are known as Horner-Tranta spots. And when they are present on the upper lid, they give cobblestone appearance to the conjunctiva. Okay, so what is the diagnosis in this case? Giant papillary conjunctivitis? No, because that is related mostly to the contact lens use. Giant papillary conjunctivitis is related to the contact lens use, so that is ruled out. Trachoma, trachoma can be there in children. It can cause itching, but you do not see ropey discharge in case of trachoma. And the lesions which are present in trachoma, they are follicles. They are not the papillae. So this will be ruled out. Vernal keratoconjunctivitis or spring catarrh is the right diagnosis, as you all had already mentioned, friends. And phyllectanular conjunctivitis is ruled out because that is, you see yellowish nodules around the limbus and no ropey discharge or itching is seen in these cases. Okay. Additional points about the VKC, they can show you the image also. So this can come as an image-based question also. I'm sure you all are familiar. We have done many times how the giant papillae they look like. So these are your raised lesions, flat top raised lesions, which are, when they are big size, they are known as giant papillae. And they are giving, as I told you, cobblestone appearance to the tarsal conjunctiva. And when these lesions, they are present at the limbus, as you are seeing here, the gelatinous papillae at the limbus, they are known as Horner-Tranta spots. Horner-Tranta spots. Okay, so simple, and I hope you will not forget these points about the vernal keratoconjunctivitis or spring catarrh. Absolutely right. Okay, ready to go ahead? Fine. Let's go ahead. Right. So now this question is, which of the following is incorrect about acute congestive glaucoma? So reading the question statement is very important, friends. Do not miss the words like incorrect, not true, is false, all except, because they can make a difference in how do you attempt the question. You might pick up the wrong choice if you do not read the case statement carefully. So I stress upon here, spend 10 seconds extra on reading the case statement carefully. Okay, so which of the following is incorrect? So I have to mark the incorrect choice as my answer about acute congestive glaucoma. Okay, so let's revise acute congestive glaucoma. The first choice is eyeball is stony hard due to high intraocular pressure. So do you guys agree that in acute angle closure glaucoma, acute attack of angle closure glaucoma, which is also known as acute congestive glaucoma, the eyeball becomes hard like a stone because the pressure goes in the range of 60, 70 millimeter of mercury, such a high pressure. So this is a true statement. The second statement, pilocarpine helps in relieving the pupil block. So yes, because if you remember, friends, the precipitating event in case of acute congestive glaucoma is when the pupil dilates. When the pupil dilates, the angle becomes totally closed due to pupil block. So you want the pupil to become smaller in size. You want the pupil to become constricted, myosed. So that is why we use pilocarpine eye drops. So yes, this is the right statement. To break the attack of pupil block, to break the attack of acute angle closure glaucoma, we give pilocarpine. Third statement, pupil is myosed and non-reactive. So myosed means smaller in size. So that is not the case. That is not the case. In acute congestive glaucoma, the pupil actually becomes mid-dilated. mid-dilated, non-reactive pupil is the sign of angle closure glaucoma. Okay, I'll show you the image right now. So according to me, the third statement is not correct. Peripheral iridotomy would prevent the future attacks of angle closure glaucoma. So that is the right statement, because the person is prone to have repeated attacks of high pressure. So if we make an additional opening in the iris, which is known as peripheral iridotomy, that will prevent the future attacks of the glaucoma. Okay. Yes, absolutely right, Dr. Vani. The pupil is vertically oval. And why the pupil is vertically oval? Let me show you. Because of the high pressure, the sphincter muscle of the pupil becomes ischemic. So this is how the eye will appear in acute congestive glaucoma, friends. In acute congestive glaucoma. Okay. So you can see the cornea is hazy because of the high pressure. Because of the high pressure, the eye is red. And look at the pupil. Look at the pupil. Vertically oval, dilated pupil. Typically, classically, vertically oval, dilated pupil. Okay. So all of you agree with me? What do you see in acute congestive glaucoma? How do we manage this attack? If they ask you, the primary aim is to reduce the intraocular pressure. So for which we can give mannitol and or Diamox or acetazolamide. And then we have to break the pupil block. So that is why we give pilocarpine. And to prevent the future attacks, we do laser iridotomy or peripheral iridotomy using ND-YAG laser. ND-YAG laser. Okay, so this is all about acute angle closure glaucoma. Okay, friends? Right? Okay. Fine. So moving on to the next question, dear friends. So acute angle closure glaucoma, signs, management, very important. And let's move on to the next question. Let's move on to the next question. Which of the following is the least likely to cause bilateral ptosis? Which of the following is least likely to cause bilateral ptosis? Okay. So ptosis, what do we mean by ptosis, friends? The drooping of the eyelids, least likely. Again, please remember this statement, that which is not the common cause of bilateral ptosis. So let me go through the choices. A, myasthenia gravis. B, chronic progressive external ophthalmoplegia. C, senile ptosis. D, Horner syndrome. Okay, so all of these, they can cause the ptosis. Yes, absolutely great. You are marking the right answer. The right answer here is Horner syndrome. So myasthenia gravis, friends, it causes bilateral ptosis, though it is usually asymmetrical. Asymmetrical means that one eye may show more ptosis than the other eye. Okay. Then there is a condition called chronic progressive external ophthalmoplegia, in which there are paralysis of all the extraocular muscles and as well as levator palpebrae superioris. So that's a common cause of bilateral ptosis. Then senile ptosis. Senile ptosis means age-related. Again, commonly bilateral it can happen. But Horner syndrome usually is not a cause of bilateral ptosis, because there the ptosis is on the affected side. The ptosis is on the affected side. Okay. Now, in this, besides the question which we did, I want you to revise quickly with me 2 points about the ptosis in myasthenia gravis. The ptosis in myasthenia gravis. So ptosis in myasthenia gravis, the peculiar thing is that it is variable. It can be intermittent, that sometimes there is ptosis because that increases with the fatigue. when the patient is fatigued, like, there may be no ptosis in the morning, but the ptosis in the evening. So variable intermittent ptosis, which increases with the fatigue, is a feature of myasthenia gravis. And this ptosis may improve. This ptosis may improve with application of ice packs. So that is known as ice pack test. This was a question in the last exam, beta. And then there is another test which is done, is known as tensilon test or neostigmine test, which again improves the ptosis when you inject the tensilon. No, beta, it does not decrease in the evening. It increases in the evening because throughout the day, the muscles, they get fatigued. Okay, Dr. Vineet, it decreases in the morning once the patient is well rested, but it increases in the evening, or if patient takes rest in between, the ptosis may get better. Okay, right? Okay. So this was about ptosis and few important points about myasthenia gravis, which is the tensilon test. Another drug which you can inject is edrophonium, which is again improves the ptosis. Moving on to the next question, beta. Moving on to the next question. Again, an important topic for your exam. Let's go through the question. Right. A type 1 diabetic patient goes for his regular fundus examination. So what is the patient? He is a type 1 diabetic. Regular fundus examination. That patient doesn't have any problem. He's just going for a regular examination. But it shows a neovascular front on the optic disc in his right eye. So this is the important information. Neovascular front on the optic disc. Which of the following is the most appropriate next step in the management? So I see the house is divided between the choice A and the choice C. Okay, interesting. So what is the diagnosis according to you, friends? What is the diagnosis in this patient? Once there is neovascular front or neovascularization on the optic disc, your diagnosis is proliferative diabetic retinopathy. Okay, so all of you agree. Now, what is the most appropriate step in the management? Will you be giving intravitreal injection of anti-VEGF drug? Or you will just observe the patient because it was a regular examination? Or you will do the pan-retinal photocoagulation laser? Or you will do the grid photocoagulation laser. So, beta, whenever there is neovascularization, the treatment, the ideal treatment is, or the most appropriate treatment is pan-retinal photocoagulation laser. Okay, so I will go with my friends which are marking the choice C. I agree with them that we will do pan-retinal photocoagulation laser. Not grid, because that is done for diabetic macular edema. That is not for the PTR. This is for diabetic macular edema. No observation because the patient can bleed anytime. So you will not wait. Anti-VEGF is not the most appropriate step, beta, unless there is some specific indication for anti-VEGF. Okay, like there is already bleeding happening and you cannot do the laser, then you will go for anti-VEGF. Okay, otherwise the first step will be laser. Laser is the, yes, pan-retinal photocoagulation laser is the most appropriate step. Okay, so anti-VEGF is not the first step for proliferative diabetic retinopathy, beta. Okay, so all of you are clear? Yes. Yes, you are very right. So I am already going to tell you what you do for NPTR. So before we go for that, just because this can come as an image question also. So please, you must know how to identify new vessels on the surface of the retina. So you can see the fronts of the new vessels on the surface of retina, dear friends. So when there are new vessels on the surface of retina, it is the stage of PDR. And what is the treatment for PDR? PRP laser. PRP laser. Okay, right? And when it is NPDR stage means no new vessels. So for NPDR stage, yes, as you told me, good glycemic control and regular examination. Keep your blood sugar under control, metabolic control. Yes, absolutely right. And when there is diabetic macular edema, okay, diabetic macular edema, then the choices are you can give anti-VEGF injection when the edema is in the center, or you can give focal or grid laser. Okay, so then the choices are these. Fine. So this is regarding your treatment in diabetic retinopathy. PDR, PRP, NPDR, glycemic control, macular edema, anti-VEGF if the edema is in the center, or focal, sorry, or grid laser. Okay, friends, right? Okay, let's move on to the next question, dear friends. After the diabetes, important topic, let's move on to another question. Here, a 24-year-old boy underwent the procedure shown in the image in his right eye. His left eye shows corneal scarring. Identify the procedure done for him. So here is a boy, a young man, okay, who underwent the procedure shown in the image, right? So one eye, this procedure was done. His other eye has corneal scarring. So what was the reason of corneal scarring? We have to see, identify this procedure. Okay, so let's come to this picture, beta. Let's come to the slit lamp picture. What do you see here, my dear friends? What do you see here? So you see there are these semicircular rings which have been implanted within the cornea. Okay, within the cornea. This is the pupil area. Pupil area is clear. So within the cornea, these rings, they have been implanted. Okay, so what are the choices? Is it an AC IOL, that is anterior chamber IOL? No, because anterior chamber IOL will be round. It will not be like this semicircular rings. And when they are giving you a hint of corneal scarring in the other eye, beta. So, like, try to see what examiner is trying to inform you. Try to see what his additional information the examiner is giving you. When he's specifically telling you the corneal scarring in the other eye, so I will not think about the lens then. Okay, I will think about the corneal diseases. I will think about the corneal diseases. Okay, so anterior chamber lens in any case will be round optic, will not be like semicircular rings. So that is ruled out. Okay, ICL. I have purposely put the short forms here because in exams, sometimes they put the short forms. ACIOL, you understand, beta? Anterior chamber intraocular lens. What is ICL? ICL is intraocular columnar lens. Intraocular columnar lens, which is an additional lens put in the eye for refractive purposes. Okay, so this is not ICL again, which is put behind the iris. So is it keratoplasty, beta? No, keratoplasty is corneal transplantation. So this is not the keratoplasty. Yes. So those who have marked the intacts, so this is the right answer. Okay, so this is relatively newer question, because they can ask you in the treatment of keratoconus. They have been asking you about C3R procedures. They can ask you about intacts. So please have a look carefully again at these intracorneal rings, beta. Intracorneal rings. Okay, they are one of the treatment for keratoconus. Okay, so the full form of these are intrastromal corneal ring segments. Okay, intacts are beta. Intacts The full form is intrastromal, that is within the corneal stroma. Corneal ring segments are implanted. These ring segments, they are made up of PMMA material. They support the thin cornea in keratoconus. They support the thin cornea in keratoconus. Okay, so are we? No worries, beta. Wrong ho gaya, no problem, Arif. This is what we are, that is the purpose of this session. That whatever we need to know, we will know. And we will do good in our exam. We will not do it. Yahan pe wrong ho gaya, no worries. Mock test mein wrong ho gaya, no worries. We have to do it right in the main exam. Okay? Right. Yes. So after Intacs, you should also know what are the other options available for keratoconus. You do rigid gas permeable contact lenses, beta, when the stage is early. You can do C3R or collagen cross linking for progressive keratoconus. Intacs when the cornea is already thin, and keratoplasty when there is scarring. So as in the other eye of this patient. Okay. So when there is scarring or the keratoconus is very advanced, then you go for keratoplasty. Okay. So are you fine? Why it is not anterior chamber IOL? Why it is not ICL? ICL is intraocular polymer lens, which is done for the patient who cannot undergo LASIK. Okay. Yes, absolutely right. Okay, let's move on to our next case scenario. Again, a very common one. Again, a very easy one, but favorite with the examiner these days. Okay, so let's read the question statement, beta. Let's move on to this question. A 5-year-old child from poor socioeconomic family had an episode of measles and is now having severe dryness of the eye. So poor socioeconomic family means the child is more likely to have malnourishment. Measles, again, it tends to give you a lot of deficiencies, nutritional deficiencies, immunosuppression. What are the features in the eye of this child now? He's having severe dryness. His cornea is becoming lusterless. His cornea is becoming lusterless in one eye. White foamy spots are seen on outer aspect of both eyes. Okay, which of the following would confirm the diagnosis in this case? So first of all, I am sure that you guys are now getting an idea that what is this case? What is this case? A child who is malnourished, who just had measles. Now, these two combinations, they put the child into nutritional deficiency case. And what are the signs in the eye? Severe dry eye, cornea becoming lusterless. It means corneal cirrhosis. Corneal cirrhosis, beta. Corneal cirrhosis. The white foamy spots. White foamy spots, they are your bited spots, beta. Because these are the only spots which has got this whitish foamy appearance. So corneal cirrhosis, dryness of the eye, conjunctival cirrhosis, bited spots. We are talking about, the examiner is talking about vitamin A deficiency. Agree with me? Yes. So if I have to confirm the vitamin A deficiency, will the corneal smear going to help me? No, corneal smear is for corneal ulcer diagnosis. Okay. Serum iron levels, this is not a sign of iron deficiency. Okay. Serum retinol levels, yes, because that will confirm the diagnosis of vitamin A deficiency. Schirmer test. Schirmer test can tell me that yes, this child does have dry eye, but what is the reason for his dry eye? I have to correct that. And already I see some signs of that diagnosis. I see conjunctival cirrhosis, corneal cirrhosis, bited spot. So I will not waste my time on Schirmer test. I already know the dryness is happening. Okay. Yes. No, there is no confusion, Dr. Chaudhary, about the first clinical sign and symptom. The first symptom in vitamin A deficiency is night blindness. Night blindness. signs. Okay. And the first sign is conjunctival xerosis, conjunctiva becoming dry. The eye surface loses its luster. Okay. So first symptom, night blindness, first sign, conjunctival xerosis. And then you can get, sorry, you can get an image question about the bited spot beta. About the bited spot, whitish foamy appearance is only seen in the bited spots. Mostly they are present on the outer temporal aspect of the eye. Okay. And this is your grading WHO classification of the vitamin A deficiency, which is called zero ophthalmia. The signs, symptoms seen in vitamin A deficiency, they fall under the heading of zero ophthalmia. And as I told you, beta, night blindness is the first symptom and conjunctival xerosis is the first sign. Okay, then followed by bited spot, corneal xerosis, corneal ulceration, which is also known as keratomalacia. And then the changes which you see in the retina, they are known as zero ophthalmic fundus. There are pigmentary changes on the fundus. Okay, right? So this is how you will diagnose and attempt the questions for vitamin A deficiency beta. Okay. Moving on to the next question, dear friends, which is the yoke muscle of the right SR? SR means superior rectus in the movement shown in the image. So extraocular muscles, again important one for your exam beta. The question is asking you to identify the yoke muscle of the right superior rectus in the movement shown in the image. Okay. So first of all, if you look at the image beta, what is the movement shown in the image? This is the right eye of the patient because patient is facing you. This is the left eye of the patient. Okay. The patient is looking right and up, right and up. Okay. Right and up means dextro elevation. Okay, so this movement is right and up. Agree? Right? Yes. And in one eye, the right superior rectus, they have already told you that this eye, the superior rectus is the one which is taking the eye up. So what is the yoke muscle? Yoke muscle is the muscle in the other eye which is helping in the same movement. Okay. So choices are right inferior oblique, left inferior oblique, left superior rectus, left medial rectus. So right goes away because only one muscle will be acting in one eye for a particular direction. Okay. So for the, yes, no, there is, I think, confusion here because some of you are writing the right answer. So if you have to identify the yoke muscle, the easiest way, so here they have just twisted the question. Actually, the answer is very simple. You know, I always tell in my class also, so right superior rectus, if I have to find the yoke muscle for this, okay, change right to the left, superior to inferior, rectus to oblique. Okay. So if they have given you one muscle, right superior rectus, the yoke muscle for that will be make right to left, superior to inferior, and recti to oblique. So that will give you the yoke muscle. So in the left eye, it is the inferior oblique which is causing the movement. So your answer is choice B, beta. Choice B. Yes, opposite. Absolutely right, Moninder. So actually this figure they have given just to increase the confusion only. So even if you do not identify the movement, they have already mentioned to right superior rectus. Okay. But yes, the question can come like this also, that which is the muscle acting in the left eye or which is the muscle acting in the right eye. Okay. So you have to see that, you know, if it is dextro elevation. So please listen here carefully for a minute, beta. If there is dextro elevation, that the right eye and up direction, right and up direction, on the right side, it will be the rectus muscle acting. And on the opposite side, it will be the inferior muscle acting. Okay, so let me show you here. Let me show you here. Once, look at this figure here to make it more clear. If it is right and up gaze, on the right side, rectus muscle will be active. And obviously, then you can find the yoke muscle in the other hand. If it is left and up gaze, then on the left side, rectus muscle will be active. Okay, so left superior rectus, right inferior oblique. If it is right and up, right rectus, right superior rectus. Okay, similarly for down gazes, if it is the right down gaze, then right inferior rectus will be active, right rectus. So same side rectus and opposite side oblique. Okay, so whether it is up, then it becomes superior rectus. If it is down, then it becomes inferior rectus. Okay, so for left and down gaze, left inferior rectus will be active. Okay, so I hope you got it better. If they ask you in particular movement, if it is right up, then right superior rectus will be active. And you can find the yoke muscle of the left. If it is left up, left superior rectus, you can find the yoke muscle of the right eye. If it is right down, right inferior rectus, the same side rectus, and you can find the yoke muscle. Okay, right? Perfect. Okay. And then, of course, do not forget the nerve supply, LR6SO4O3 beta, nerve supply. Lateral rectus by 6th nerve, superior oblique by 4th nerve, and rest all the muscles by 3rd nerve. Okay. So beta, just want to emphasize what Shiv Kheda told us. Your positive action combined with positive thinking is going to result in success. I think this should be in your mind these days. You are doing positive reaction. You have worked hard in preparation for your exam. Just supplement it. I would say not supplement, complement it. Okay. Your positive hard work, complement that with positive thinking. Your hard work is going to pay better. Have faith in yourself. You are doing fine. You are now going to work harder. And with that positive thinking, I'm sure all of you are going to come with flying colors in your upcoming exam. So let's be positive in everything we do. Yes. Okay, perfect, guys. Yes, additional information or the 7th nerve supplies the orbicularis oculi muscle. Absolutely right. Now, coming on to the next question, which is based upon the refraction beta, because this topic again is now becoming important for your exam. The following findings are seen in a girl when retinoscopy is done. Okay, so they did the retinoscopy and they found this cross. How the retinoscopy was done? It was done under atropine at a working distance of 1 meter. Okay. So what is the type of refractive error shown here? So in one axis, so as you notice here, beta, at 90-degree axis, the +3 diopter was found, and at 180-degree axis, +5 diopter was found. Okay, so what is this type of refractive error? Is it simple hypermetropia? No, because simple hypermetropia means the power should be same in all the axes. So this is not the right answer. Is it a simple myopia? No, it is a plus lens. Myopia is corrected by neutralized by minus lens. So this is not the right answer. Compound hypermetropia? Yes. Compound means that hypermetropia corrected by plus lens. Compound means the power is not same at all axes. Yes, because here at 90-degree, the power is +3. And at 180-degree, the power is +5. It is not same. So this is my answer here. Compound myopia, no, again, because of the same reason, it is neutralized by the plus lens. Yes, compound hypermetropia is the right answer. So if the power is different at different axes, then it becomes compound. Okay, if it is neutralized by plus lens, then it is hypermetropia. If it is neutralized by minus lens, then it is myopia. Okay, and supposedly, beta, you have to convert this retinoscopy into your glass prescription. So how will you convert this into your glass prescription? This was a question in the last exam, beta. So let's do it here. Yes. So here you have to mention that what are the conditions? So here they have mentioned the working distance, 1 meter. And they also used cycloplegia, that is atropine. So once these are the conditions, then you have to make correction for working distance and for atropine. So if 1 meter working distance is there, you will subtract -1 diopter. You have to subtract reciprocal of the working distance. Okay. For atropine, we subtract 1 diopter for the cycloplegic correction. Okay. So in this case, if I am doing this, my retinoscopy will change. I have to do -1 here. I have to do -1 here. Okay. So now what will be my corrected cross? My corrected cross becomes +1 here and +3 here. My corrected cross becomes +1 here and +3 here. Okay, right? Yes. So now how do I choose the correction? Now go for the smaller power as severe, beta. Go for the smaller power as severe. That is one diopter I will give as spherical power. +1 diopter severe I will give as spherical power. Now when I have given +1 diopter severe, that will act all along. So what will be the residual left here? +2. +2 residual is needed at 180 degree. +2 residual is needed at 180 degree. So I have to give +2 cylinder. Okay. But where will I give the +2 cylinder, beta? So please listen carefully. Cylinder acts at 90 degree to where it is placed. It acts at 90 degree to where it is placed. If I want action at 180 degree, then cylinder has to be placed at 90 degree axis. Okay. So this will be my glass prescription for this case. So once again, the smallest power I will give as severe, that is +1. Then +2 residual is left at 180 degree. So this +2 will be given as cylinder, but I need the power at 180. So I have to place that at 90 degree because the cylinder, they act 90 degree to where they are. Okay, right? So this is how you will convert your retinoscopy finding into glass prescription, beta, if the question comes like that. Are we good with that? Okay. Moving on to the next question, beta. Moving on to the next question. Yes, move on to the next question. Nikhil, once again, I can, of course, explain. See, this was your retinoscopy finding. So first of all, you have to convert it into the corrected cross. Okay. You have to subtract the working distance, reciprocal of the working distance. So for 1 meter, it becomes -1 diopter. You have to subtract the cycloplegic correction. For atropine, we take it as -1 diopter. So usually these are the conditions which they give you. So this becomes your, so +3 + 5 now will become +1 and +3. Now severe, how to choose the severe? Severe acts all around at all the axes. So you choose smaller power as the severe. So +1 you give as severe. Okay. And then the rest remaining, which is there at 180 degrees, now +2, that will be given as cylinder. Now cylinder has to be placed 90 degree to where it is required. So here the cylinder is required at 180 degree. So I place that at 90 degree. Okay. So +1 diopter severe, +2 diopter cylinder, that has to be placed at 90 degree. Right? Okay, beta. Okay. Okay, let's move on to the next question, beta. A young male, oh, wow, some of you are so fast. You have already given the answer before I read the question. A young male suffered penetrating injury to the left eye with an iron nail. On examination, the uveal tissue prolapse was seen in the ciliary body area. This boy is at risk of developing which of the following conditions? So classical case scenario, they have given you all the required information to make a diagnosis. So what are the key points here, beta? Penetrating injury, okay, with iron nail. So penetrating injury means there is some corneoscleral perforation or laceration. The uveal tissue prolapse was seen, that because of the injury, the uveal tissue is coming out. And even the site of the injury, they have given ciliary body area. So penetrating eye injury involving the ciliary body area is a high risk factor for, yes, absolute right, sympathetic ophthalmitis. That is why ciliary body area is also known as dangerous area of the eye. Okay. And what is the nature of the uveitis which you see in sympathetic ophthalmitis? See, give and place is the same thing, Abanar Ravi. I mean, you give at 90, then it will act at 180. Okay. So I need it to act at 180. So that is why I'm giving at 90. Okay, right? Yes, when we need to give at 180, so that is why then we place it at 90. Yeah, yes, absolutely right. So what I was asking, what is the type of uveitis you will see in sympathetic ophthalmitis? That is, beta, always remember, it is bilateral, it is granulomatous, it is panuveitis. Okay, so please remember these 3 points. Or you can make it like, BPG also. Bilateral, panuveitis, granulomatous. If you want to remember something like BPG, bilateral, panuveitis, granulomatous. Penetrating eye injury is the prerequisite. Ciliary body area injuries are usually very dangerous for developing sympathetic ophthalmitis. Okay, right? Okay. Moving on to the next question, beta. Moving on to the next question. Let's read the question. A young girl has been using soft contact lens. So, soft contact lens uses there. However, she occasionally washes them with tap water and also shares her lenses with her friend. So, she's using the lenses, but her practices are very unhygienic. She's cleaning them with tap water. She's sharing her lenses with her friend. Okay. Recently, she developed painful red eye. Identify the lesion marked in the given image. So this girl now developed painful red eye. So contact lens use with poor hygiene. Patient developing painful red eye. It means the patient is having corneal ulcer. Patient is having corneal ulcer. And here you have to identify what is the lesion, beta. What is the lesion? See carefully. See carefully. What is the lesion? You are seeing a ring ulcer, beta. You are seeing a ring ulcer. You are seeing a ring ulcer. Look at the typical shape of the ulcer. It is ring ulcer, beta. Okay. So this is not a dendritic ulcer. This is not a satellite ulcer. Satellite ulcer is seen in fungal cases. The shield ulcer is seen in VKC, spring catarrh. Okay, so please again go through this question. A girl who is having soft contact lens use, okay, but unhygienic practice, so she develops corneal ulcer. So yes, one of the most common causes will be pseudomonas. But if I need to talk here, they're asking me to name the lesion. So here it is a ring ulcer. Choice A becomes the answer. Right? Ring ulcer, which is caused by, so here it is actually a case of acanthamoeba keratitis. Acanthamoeba corneal ulcer or keratitis. Okay, are you good with that, beta? Yes, yes, right? So just to let you know that what other ulcers they can ask you as the image signs. What other ulcers they can ask you as the image sign? Try to identify this lower lesion, beta. Try to identify this lower lesion which I am showing you. This is your dendritic ulcer. Yes, that's right. This is your dendritic ulcer. So they can show you that. This is what they showed you in the last exam, beta. And look at the upper one. Look at the upper one. This is your geographic ulcer, beta, or amoeboid ulcer. Geographic or amoeboid. So both of these, they can be seen in herpes simplex viral keratitis, right? And look at this picture, beta. Look at this picture. There is a main ulcer, and then you are seeing these satellite lesions. So if they ask you to mark this, these are the satellite lesions. And they are feature of fungal corneal ulcer, beta. Fungal corneal ulcer. Okay. So I have shown you all the images here, beta. If there is a ring ulcer, you can mark the ring ulcer, which is acanthamoeba keratitis. If they show you the dendritic ulcer, you can identify the dendritic ulcer. Geographic ulcer, you can identify. And you can identify the satellite lesions, which are feature of fungal corneal ulcer. In fungal corneal ulcer, beta, sometimes they can give you the case history in which there will be trauma with the vegetative matter. A farmer getting injured by vegetative matter, tree twig, then the chances of developing fungal corneal ulcers are there. Okay, right? So this is how you will identify the lesion in different type of ulcers, beta. Good? Okay. Moving on to the next question, beta. A 15-month-old child is brought by his parents who noticed white reflex in his left eye lately. So look at the age group. Again, go step by step. 15-month-old child. White reflex, leukocoria. Okay, second key point, white reflex. On examination, shield ulcer, beta, is seen in VKC. That's like a shield, like a central area, something like this. So because that can be, that will be like this. If this is the ulcer, and if you stain it like this, that will be completely in the central area, a shield-like area is there. Since it is not alone, okay for the lesion identification, so it's unlikely that they will ask you to identify or mark the shield ulcer. Okay, right? Yes, beta. Yes, you guys are absolutely in the right direction. So white reflex. Then on examination, total retinal detachment is seen. Okay. And then on ultrasound, the mass is seen with calcification. So all these are your key points, beta, in this information. A child, age group, 1.5-year-old, okay, white reflex, a mass in the retina with calcification. Your diagnosis should be retinoblastoma. Okay, so congenital cataract can cause leukocoria, but it will not cause any calcification or retinal detachment. Coats disease causes again leukocoria and subretinal exudation, but no calcification. Okay, it causes subretinal exudation of the lipid kind of material, but no calcification. Okay. Then rhabdomyosarcoma is an orbital tumor, most common orbital tumor of childhood. So white reflex, mass with calcification, retinoblastoma, beta, that should not be a doubt there. Okay, that should not be a doubt there. So they can show you the image. Calcification is the key point here, beta. Calcification is the key point here. So they can show you the image also. You can identify the leukocoria. Another thing which you should remember is the Flexner Wintersteiner rosette, which are specific histopathological feature of retinoblastoma. Okay, so even this can come as an image question. Yes, Yes, if you see retinoblastoma, mark it, of course, after looking for the keywords, beta. Okay, don't mark it indiscriminately also. So leukocoria, flaxen intestinal rosettes, again, they can ask you. Moving on to the next question, beta. Moving on to the next question, another favorite these days with the examiner, the cataracts, the management of the cataracts. Okay, a child is diagnosed with congenital cataract, okay, and is being planned for the cataract surgery. So here the question is about the management of the congenital cataract. Yes, beta, I'm not, I'm in India at the moment. My time is absolutely what I am where I am now. So, but that doesn't matter. We are always connected. We are always connected, right? So congenital cataract child is being planned for the surgery. Now, what is true about the management in this case, beta? What is true about the management in this case? So congenital cataract management, important thing, beta. Let's go through the choices one by one. Bilateral congenital cataracts, they cause more amblyopia than unilateral cataracts. So is it a true statement or false? It is a false statement because unilateral cataract, they cause more amblyopia than bilateral. Okay, because one eye having cataract causes more suppression of the vision, more amblyopia. Okay, every child should be given full intraocular lens power correction. So that is again not the true statement. I'll just tell you why. Because you have to undercorrect the IOL power calculation, IOL power which is given to the child according to the age of the child. Myopic shift could lead to change in the IOL power. Yes, that is the true statement. So this is my answer. Lensectomy is the ideal procedure, ideal surgical procedure. No. Lensectomy means that you are removing whole of the lens with the capsule. So if you remove the capsule, then you will not be able to place the intraocular lens in the capsular bag. So that is not the ideal surgical procedure. Okay. Sorry. So here in this case, in congenital cataract, the first is that unilateral, they cause more amblyopia. Then IOL power calculation has to take care the factor of myopic shift. This was the question in last exam, beta. Myopic shift means, we have learned that a child is born with a smaller eyeball. So a child is born hypermetropic. Now, as the eyeball grows, as there is increase in the size of the eyeball, increase in the axial length, the refractive status of the eye becomes myopic. From hypermetropic, it undergoes myopic shift. So to consider this myopic shift, you have to make undercorrection of the IOL power, beta. Undercorrection of the IOL power. Okay. So if it is less than 2 years of the age child, give 80% of the IOL power. If the child age is 2 to 8 years of age, give 90% of the IOL power. And more than 8 years, you can give full IOL. Okay. So for children, myopic shift is to be considered. Then what is the surgery? The surgery is again the phacoemulsification. We are not doing the lensectomy. We are doing the phacoemulsification. Okay. We are putting the lens, and one additional step which is done is known as posterior capsulotomy. Posterior capsulotomy, that you do make an opening in the posterior capsule during the surgery itself, because to prevent any after cataract in the children. Because if there is after cataract, so again the purpose of the surgery is gone. The child will have blurred vision and amblyopia. So you do the posterior capsulotomy during the surgery itself. Okay, right? Okay, perfect. So myopic shift, do not forget the undercorrection of the lens power for myopic shift. Moving on to the next question, beta. Moving on to the next question. A 60-year-old gentleman presents with watering and discharge from the left eye for 6 months with swelling close to inner canthal area. So an elderly person is having watering and discharge as well as swelling in the inner canthal area, right? The following findings are seen on examination. So look at there, beta. What are the findings seen on examination? That when he is pressing this inner canthal area, you can see this discharge coming. So when he is pressing at the lacrimal sac area, so this is the lacrimal sac area, the discharge is coming, right? So he is a case of, what is your diagnosis, beta? 6 months, 6 months. So there is infection of the lacrimal sac area, that is dacrocystitis, okay? Chronic, it has been there since long, 6 months. So what is the most appropriate treatment for him? Will you go for sac massage and antibiotics? So this alone will not help. Antibiotics followed by DCR. Yes, you have to do the DCR because it's a chronic case now and patient is having chronic infection. But you will not go straight away for the DCR. First, you will control the infection. So most appropriate treatment will be antibiotics followed by DCR. Silicone intubation for chronic cases, this is not going to help. You have to go for DCR. You have to go for DCR. Okay. So antibiotics followed by DCR, beta, the choice B is the appropriate one. Okay. So what is done in DCR? This image was there. This is your DCR punch, which is done in the DCR, used to make a fistula or an opening between lacrimal sac and middle meatus. So you punch this bone here with the bone punch, and now you create a new opening between the lacrimal sac and middle meatus area. So that is the treatment of DCR. Yes, this punch was an old past year question, beta. Okay. Then at the same time, do not forget the management of congenital nasal lacrimal duct obstruction also, beta. Congenital nasal lacrimal duct obstruction treatment also. If the child is less than 9 months of the age, sac massage. After 9 months of the age to 4 years of the age, syringing and probing. After 4 years of the age, DCR. Okay, so please remember for children also, right? Okay, beta. Moving on to the next question, friends, here. A 70-year-old lady. Let's move on to the next question, beta. A 72-year-old lady suffered stroke involving occipital lobe. Which of the following field defect could be seen in these cases? So visual field defects, beta. Yes, ProPic can also come, beta. I have shown you in the revision classes. So visual field defects, another high yield topic for your exam, beta. If there is the stroke involving occipital lobe, what do you expect? What do you expect, beta? Macula sparing homonymous hemianopia, macula involving homonymous hemianopia, macula sparing bitemporal hemianopia, superior quadrantopia. Perfect. So all of you have given me the correct answer there. Occipital cortex lesions, they lead to macula sparing homonymous hemianopia. Perfect. And let's quickly revise the different lesions with the visual field defects, beta. If optic nerve is gone, then it will be monoocular defect. Okay. If optic chiasma, the chiasma is involved, then you get bitemporal hemianopia. And please remember, the most common causes of the chiasmal lesion is your pituitary tumors, right? If optic tract is gone, that causes homonymous hemianopia, but involving macula. Okay, optic tract, number C, homonymous hemianopia involving macula. So here you are seeing pie on the floor. which is seen in parietal lobe lesions. Here you are seeing pi on the sky, in the sky, that is superior quadrantopia, temporal lobe lesions. And here you are seeing macula sparing homonymous hemianopia in the cases of occipital lesion, right? Okay, so please remember how these visual field defects, they look like, how the macula sparing looks like, how bitemporal looks like, and the site beta. Okay, so in the visual field, this thing, please revise the site as well as the appearance of the visual field defect. Okay, right? But for optic radiations, the one which pass through parietal lobe, if there is parietal lobe lesion, then it is pi on the floor, inferior quadrantopic. If it is temporal lobe lesion, then the optic radiations which are in the temporal lobe, they are affected, they cause pi in the sky, superior quadrantic lesion. Okay, beta? Okay, let's move on to the next question, friends. Again, very commonly asked. By now, I think everybody can make the diagnosis here. Let's go. A hypertensive man presents sudden painless loss of vision. So hypertensive, sudden painless loss of vision in his right eye. On examination, the vision is 5/16 right eye. Proud of you guys. You are right on the diagnosis. Anterior segment is normal. Fundus examination shows multiple retinal hemorrhages in all the 4 quadrants of retina. But this is the key word. Multiple retinal hemorrhages in all the 4 quadrants of retina. What is the most probable diagnosis? So as you already told me, when you see whole of the fundus, so have a look here, beta. Whole of the fundus splattered with retinal hemorrhages. You can see whole of the retina is full of retinal hemorrhages. This is your CRVO. Tomato splash appearance, blood and thunder appearance. 100 times we have done this. Complication 100-day glaucoma or 90-day glaucoma here. Okay. So this is your CRVO. They can sometime put just the abbreviation in one of the exam. They just put the abbreviation. So carefully mark the abbreviation CRVO. Okay. This is not retinal artery occlusion. This is not branch retinal artery occlusion. There can be macular edema, but the full diagnosis is CRV. Okay. And let me just make you revise quickly what the other fundus, the vascular occlusion will look like. So if the retinal hemorrhages are involving 1 quadrant of the retina, then this is BRVO beta. Okay, 1 quadrant of retina, BRVO. If it is cherry red spot in the center, red spot in the center, pale ischemic retina elsewhere, then this is CRAO, central retinal artery occlusion. Yes, perfect. Okay. So these 3 conditions, beta, CRVO, BRVO, CRAO. So all of them, they can present with sudden painless loss of vision, but try to see what are the fundus findings. What are the fundus findings? Okay, right? Okay, beta, moving on to the next question. A young girl is diagnosed with refractive error of -2 diopter sphere, -1 diopter cylinder at 90 degree. However, she is not happy wearing the astigmatic lenses. Okay, which of the following could be given as alternative glass power to her? Okay, so because some people who have cylindrical power, they do not feel comfortable wearing the cylindrical glasses. So is there any alternative to them? That is what the examiner is asking you. And what choices he is giving to me? I can give her spherical equivalent. I can give her spherical correction. I can give her only cylindrical correction. IOL correction. Okay, so I think there is some doubt here, beta. See, Patient is having normal refractive error, but some cylindrical power. Why do you want to change her lens? Intraocular correction, lens correction means that you want to do the cataract surgery for her. Why would I do the cataract surgery for her? Okay. Only cylindrical correction does not make a sense because she does not want to wear the astigmatic glasses. If I give only spherical correction, that will be insufficient because you are not correcting her refractive error completely. So the option here is to give spherical equivalent of her glasses. Okay, so spherical equivalent of the glasses. So what is spherical equivalent? See, spherical equivalent means, see, supposedly this is the spherical power and this is the cylindrical power. Now, spherical equivalent means that I am going to give only sphere, but how will I calculate this sphere now? I will give the sphere plus half of the cylinder, half of the cylindrical power. Okay, so I will omit the cylinder by doing this. So in this example, beta, in this example, if you see -2 diopter sphere. So -2 diopter, I will give her complete. Okay. And then I have to give half of the cylinder. So half of the cylinder will become -0.5. And the spherical equivalent in this case will become -2.5. -2.5. So you get that, beta? No, you need not take any enalapril. This is just, I'm letting you know what the spherical equivalent is. Okay. So even if you just remember that if a person is not having, not happy with the cylindrical power, what you can do? You can give spherical equivalent. How do we calculate spherical equivalent? That is an additional information. Even if you don't remember that, that's fine. I do it by adding half of the cylinder to the sphere. Half of the cylinder to the sphere. Then I need not give cylindrical power to that person. I can go sphere with in the glasses only. Okay, so is this question all right, beta? I give spherical equivalent. And how do I calculate spherical equivalent? Sphere plus half cylinder. Okay. No, you won't forget anything, beta. Don't worry. Just take each day as one day. Okay. And just concentrate on the task which you are doing. Don't let your mind waver. If you are doing one subject, at that particular moment, stay in that subject. Don't think that, oh, I'm forgetting medicine now or I'm forgetting pediatrics now. Okay, right? Okay, so let's get back here, beta. Let's get back here to your next question. Which of the following is the best treatment for grade 2 pterygium? So grade 2 pterygium is the one which is covering the cornea, which has crossed the limbus. Okay, so what is the best treatment for pterygium? Yes. It is conjunctival autograft. So here, beta, I want to clear the doubt. Many people, they confuse that whether they should go for mitomycin or conjunctival autograft. Mitomycin is also one of the choice. Okay, but over the mitomycin, the conjunctival autograft will be preferred because that has less complications. Okay, so if you have to choose between the mitomycin and conjunctival autograft, go for choice B. Am I clear here, beta? Because many people, they get this. Simple excision is not the answer because that can lead to high recurrence. Okay, observation usually not preferred because it's crossing the limbus and it is now causing astigmatism, cosmetically not good. Okay, right? So pterygium can come as your image question also, beta. The best treatment, conjunctival autograft. The best treatment to prevent recurrence, conjunctival autograft. Other choices are you can go for amniotic membrane transplant also. You can go for mitomycin also. But best is conjunctival autograft. Mitomycin, you can go to prevent the recurrence. But if, again, I'm repeating myself, if the choice is between autograft and mitomycin, pick autograft because that has less complications. Okay, right? Perfect. Okay, moving on to the another question, beta. A gentleman is recently diagnosed with primary open angle glaucoma. He's a known hypertensive and past smoker with COPD. Which of the following is true in the management of his glaucoma? Mitomycin, of course, we can give to prevent recurrence, beta, but nowadays the choice is between mitomycin and this thing. You did autograft, but still the patient is having recurrences. Then yes, of course, you do mitomycin. But when we have to choose as a straightforward answer, go for conjunctival. Okay? So primary open angle glaucoma, beta, glaucoma management drugs, one of your important topics. So here is a patient of primary open angle glaucoma who is a hypertensive, who is a smoker with COPD. So what is true in the management of his glaucoma? He cannot be started on post prostaglandin analog. So do you think there is any contraindication for prostaglandin analogs? No, beta, he can be started on prostaglandin analog. The COPD is not a contraindication for this. Okay, so this is the false statement here. Acetazolamide is contraindicated in this case. Acetazolamide has again no contraindication as far as hypertension is concerned or COPD is concerned. It is contraindicated in sulfa allergy or in kidney problems, but not in this case. So this is again false here. Selective laser trabeculoplasty is one of the treatment options. So if you remember, beta, we know the therapy, the management of glaucoma can be divided into medical therapy, laser therapy, and surgery. And for open angle glaucoma, laser trabeculoplasty is the laser which is done. So this is the true statement. Okay. Rather, these days, many patients, they are started with laser trabeculoplasty sometimes before the drugs also. Okay. So selective laser trabeculoplasty is one of the treatment options. And the choice D is he can be started on combination of brimonidine and timolol. So here, brimonidine, I do not see any contraindication, but timolol, beta. Timolol is your beta blocker, and beta blocker is contraindicated in COPD. So this is the false statement. Okay. So please remember the side effects and contraindications of the drugs, anti-glaucoma drugs. So here, are you clear, beta, why I have marked choice C? Now, especially the side effects, the beta blocker are the one which have lot of systemic side effects. So they are contraindicated in COPD. They are contraindicated in asthma. They are contraindicated in heart blocks. Okay, so please remember these contraindications of beta blockers: COPD, asthma, heart blocks. The acetazolamide has a lot of side effects, but contraindications will be acetazolamide. The contraindications will be, to remember, sulfa allergy and renal failure, the main ones. Renal failure. Okay. And brimonidine, the contraindication is in children, beta. Brimonidine contraindication in the children. Prostaglandins, they have minimal systemic side effects. Prostaglandins are one of the safest drugs because they have hardly any systemic side effects. Of course, you will not give them in pregnancy. Okay, right? Yes, brimonidine can cause sleep apnea. Okay, beta, moving on to the next question. So glaucoma drugs, do revise your side effects once. Okay. So moving on to the next question, my dear friends, a patient presents with severe blurring of the vision in the right eye, right? On examination, anterior segment is normal. there is severe vitreous inflammation. So this is the key information, severe vitreous inflammation and a yellowish lesion seen in the macula, giving headlight and fog appearance. So guys, they have given everything. They have given everything. Okay? Which of the following could be the most likely diagnosis? Severe blurring of the vision, severe vitreous inflammation, a yellowish lesion in the macula giving headlight and fog appearance. Perfect. All of you are right. Toxoplasmosis. VKH, sarcoid, syphilis are not the diagnosis. Headlight and fog appearance due to a macular lesion, the retinitis patch in the macula, and severe vitreous inflammation is seen in toxoplasmosis. And this is how the headlight and fog appearance looks like, beta. So this is the retinitis patch in the macula, retinochoroiditis patch. And because of the vitreous inflammation, the view is very hazy. So that is why headlight and fog appearance. Another additional point which I want to let you know, that when it heals, the toxoplasma heals, it can leave a punched out scar in the retina. No, in uveitis, beta, the vitritis is so severe. Toxoplasma is a uveitis only. And this is the only condition in which vitritis is so severe. And usually you will see a single lesion in the macula. So that is why headlight and fog appearance. Toxoplasma is a type of posterior uveitis. Okay? So when it heals, it can leave punched out macular scar. Punched out macular scar. So that is again seen in cases of, yes, posterior uveitis. That is again seen in cases of toxoplasmosis, punched out macular scar. Okay. Yes, Dr. Masood. So it's the same thing. Posterior toxoplasma is the most common cause of posterior uveitis. Okay, right. Moving on to the next question, beta. A 30-year-old lady presents with decreased vision in the right eye with painful ocular movements. Okay. She also feels the colors are not sharp with her right eye. So there is decrease in the vision. There is pain on ocular movement. The color vision is affected. Okay. On examination, there is a relative afferent pupillary defect and optic disc is swollen. Which of the following investigation should be done to confirm diagnosis in this case? Okay, so very good question, beta. Very good question. Try to first of all make the diagnosis. A lady, decrease in vision with painful ocular movements, color vision affected, relative afferent pupillary defect. So color vision affective, RAPD, sign of optic nerve disease, beta. Already they have told you optic disc is swollen. Optic disc is swollen, right? So let me tell you what are there here. Painful, let me summarize. Painful decreased vision, defective color vision, RAPD, swollen optic disc. That is, there is inflammation there most likely. So what does this point? Yes, that's perfect. Dr. Shah, Dr. Shinde, Dr. Rajput, this is a case of optic neuritis. This is a case of optic neuritis, beta. Okay, agree with me? Now coming back there, what is the age group? Adult. What is the most common cause of optic neuritis in an adult patient? Yes, multiple sclerosis. So multiple sclerosis is the most common cause of optic neuritis in an adult patient, demyelinating disease. So to confirm the diagnosis in this case, in multiple sclerosis, which investigation is going to help me, beta? Lumbar puncture. Lumbar puncture is not going to help me in making the diagnosis, and it is an invasive investigation, right? So I will not go for this. MRI of the brain and orbit. Yes, because that will help me in ruling out any demyelinating disease also. Okay, both A and B, I don't need lumbar puncture as the first go if I can get my diagnosis on MRI. But a fundus fluorescent angiography can help me in showing the leakage from the optic disc, but that will not help me in making the confirming the diagnosis. So we have to see what examiner is asking. So to confirm the diagnosis, MRI brain and orbit, because that will let me know there is optic neuritis. That will let me know whether there is any demyelinating disease like multiple sclerosis. Okay, so this is the right choice here. MRI brain and orbit. This can present as a simple scenario to make a diagnosis. So you have to make a clinical diagnosis that you have already done, optic neuritis. What is the most common cause of optic neuritis? Demyelinating disease or multiple sclerosis. Okay, right? Yeah, okay. Moving on to the next question, beta. An elderly gentleman presents with watering and on examination, the following image is seen. What is your diagnosis? So an image-based question, beta, come to the image here. So this patient is having watering and this is his, methylpred. The pulse therapy with the methylpred is the treatment if the diagnosis is multiple sclerosis. Beta, what do you see here? Is there any abnormality here? No, this is normal. Is there any abnormality here? Yes, you can see the lower lid is turned outward. The lower lid is turned outward. No, beta. What is this outward turning? Outward turning of the lower lid. It is not inturned. It is outward turning of the lower lid. So the diagnosis is choice C, beta, ectropion. So you should know, the lid is outrolled. If it is inrolled, that is entropion. If only eyelashes are inturned, then that is trichiasis. If it is drooping of the eyelid, then it is ptosis. Okay, so patient is having watering because the tear film cannot be held in place. So that there is watering because of the severe ectropion. Okay, so you must know what is ectropion, what is entropion, what is trichiasis. Okay, done. Moving on to the next question, beta. A boy is hit on the eye by a cricket ball and develops double vision. Beta, trauma, again important topic. The eye trauma, high yield topic for your exam. Now this boy is hit by cricket ball and now he develops double vision. All of the following could be the reason of his double vision except iridodialysis, Vossius ring, subluxation of the lens, blowout fracture of the orbit. Okay, so if eyeball is hit by a heavy object like a cricket ball or tennis ball, so that causes blunt trauma to the eye, which can affect the different structures of the eye. Now, some of these injuries, they can lead on to the double vision or diplopia. Okay, so iridodialysis, let me show you the picture. Here you have to rule out, beta, except you have to rule out what does not causes the double vision. So let me show you what the iridodialysis looks like. This is iridodialysis, beta. When iris gets separated from its root, okay, so this leads to D-shaped pupil. The pupil has become D-shaped, but you see now there are two openings. So patient can have diplopia due to iridodialysis. The two images are seen. Okay. Then the patient can also have subluxation of the lens. Subluxation of the lens, that the lens gets displaced because of the trauma. Okay. So this partly the lens is in the pupil area. So this part has lens, this part has no lens. So again, this can cause double vision because one part is having lens, one part is not having lens. This can cause double vision. Okay, so I told you iridodialysis can also cause double vision, and subluxation of the lens can also cause double vision. So this can cause, this can cause. Blowout fracture of the orbit. Okay, so when there is blowout fracture of the orbit, the inferior rectus muscle gets trapped, and that can also lead to diplopia beta because the eye is not able to move, right? But Vossius ring, the Vossius ring is how it looks like. This is your Vossius ring beta. This is your Vossius ring. It is just a pigment deposition on the lens. It does not cause any diplopia. It does not cause anything actually. Right? It is just a sign of blunt trauma. It does not cause any symptom per se. It is just a sign of blunt trauma. Okay, so all these three beta, they can be asked as image question also. So that is why I showed you image. Iridodialysis, remember D-shaped pupil, iris detached from its root. So subluxation of the lens you can identify. And when there is a brown ring on the lens surface, that is your Vossius ring. Okay, yes, it is just an impression. So all these, they can be seen in blunt trauma, but double vision will not be caused by Vossius ring. So if I have a question like that, I will choose B choice as my answer. Okay, right? So I have tried to make you revise all the features which we see in blunt trauma. And what do you see in the retina beta? Just to complete the thing, in blunt trauma, you see Berlin's edema. Berlin's edema, which again is a cause of cherry red spot. When there is blunt trauma, most common cause, it's difficult to say, beta. It depends upon how much injury the person is having. So that is not a very relevant, I would say, clinical finding. Okay, right? So they're not going to ask, a person may develop, iridodialysis usually develops when there is very, very severe trauma. But there is nothing like what is most common. Okay, Berlin's edema or the cherry red spot due to blunt trauma on the retina can also occur when there is blunt trauma. Okay, right? Okay, moving to the last question of the session, beta. Moving to the last question of the session. And in the blowout fracture, please remember the image also. You know the teardrop sign. Okay. Last question of the session, my dear friends. Identify the procedure being done here. Let me show you the procedure. Identify the procedure being done here. First of all, let's go through the choices. IOL implantation, that is intraocular lens implantation, glaucoma drainage implant, squint surgery, intrastromal corneal ring implants. Okay, now have again a look at the image. So what is this? Okay, great. Yes, guys, you are right. Most of you are right. It is glaucoma drainage device or glaucoma drainage implant or seton surgery. Okay, so what you are seeing here is actually a tubing. This is a tubing which you see here. Now this tubing goes into the interior chamber. This is a foot plate of the implant which will be there in the subtenon space. Okay, and this is a glaucoma implant. This is a glaucoma drainage implant because you put this tubing into the interior chamber so that aqueous outflows through that. The aqueous outflows through that. Yes, this is Ahmed glaucoma. Right. Okay, so obviously this is not your intraocular lens. This is not a squint surgery. There is an implant there. And I already showed you intrastromal corneal ring implants, the semicircular rings. Please don't forget them. Okay, so this is your glaucoma drainage implant. Ahmed, well, typically, this is not the lens, beta. IOL, you know, IOL will be round and it will have two haptics like this. Okay, and it's very, very thin. This is not A, this is B, glaucoma valve surgery. Okay, have a careful look here. This just has a tubing on the end and a foot plate. This is the foot plate. This is not the intraocular lens. Okay, right? So perfect, guys. This was a wonderful session with you. Okay, and as I told you, stay positive. All of you are doing hard work. Have faith in your heart. Okay, the mind is supposed to wander. Okay, but let the heart be in the place. Right? Let your mind wander, but then let your heart bring it back to the place, because what does the heart wants? The heart wants to succeed in the exam. Okay, so that is your heartfelt wish. That is my heartfelt wish, that you should succeed in the exam. And to succeed in the exam, keep going. May the success be always with you. Our best wishes are with you. We at MIST are at your disposal to solve any queries. You can contact us on the Telegram. You can contact us on the mail. I hope this session will be useful for you. We have tried to cover all the high yield topics. Use your common sense in the exam. The questions, they can be tricky, but they are not always tricky, beta. So try to think in the straight line, read the question statement carefully, and do not spend extra time on difficult questions. Okay, so keep going. We are with you. May the success always be with you. May the God will always be with you. And of course, we at MIST, I, Dr. Anuradha Dhawan, I'm always with you. All the best, my dear friends.